So it is my great pleasure to introduce our keynote speaker today. Theresa Straathof works as an occupational therapist at the Ottawa Hospital with 30 years of experience in acute psychiatry. She holds a diploma in adult education. She has written two books. One is Coping Strategies to Promote Occupational Engagement and Recovery, and the second is Coping Strategies to Promote Mental Health. Both books contain training modules and sheets on a wide range of topics to promote resilience. She has presented at numerous national and international conferences on topics related to behavior activation, coping strategies, use of Knoll's adult learning model, and suicide prevention. She's a member of Canadian Association of Occupational Therapists Network, addressing suicide in occupational therapy practice. Theresa will talk about promoting mental health post stroke, coping strategies, uh, content and teaching process. And we look forward to your talk this morning, Theresa. Welcome.
Thank you so much. It's really a pleasure for me to be here today, and thank you for that introduction. I'll start with a land acknowledgement. So I work at the Ottawa Hospital, and TOH respectfully acknowledges that it's located upon traditional and unceded Algonquin territory. We have the privilege and responsibility to serve First Nations, Métis, and Inuit, and to demonstrate respect for the contributions and traditional knowledge of all Indigenous cultures. So you've heard a little bit about me already, but I'll just say that most of my career as an occupational therapist has been in acute psychiatry. And mental health and stroke recovery are similar because there's often a multitude of factors that are impacting function and many losses that people have to manage. Also, as healthcare professionals, we're dealing with time constraints and limited resources. So we have to really be efficient when we're addressing and teaching coping strategies that are evidence-based and practical. So working in mental health, suicide prevention, and doing my diploma in adult education has really helped me to develop a structure to address coping strategy content and a teaching process, as well as addressing key factors that help with relapse prevention. So as author of the manuals that you described, I would receive royalties if copies are sold as a result of this presentation. I'm going to refer to content from both of the books today. And I also would like to say that I'm receiving an honorarium for speaking today. So thank you for that. So I really enjoyed listening to Brian and Corey's talk this morning. And I think it really hits home the idea that all people who have experienced a stroke should be considered at risk for post-stroke depression, and that can occur at any stage in the recovery. If depression and high levels of anxiety are present, then pharmacological treatment and cognitive behavior therapy by an appropriate professional is best practice. But there's a lot of other coping strategies that are helpful to promote recovery and resilience, and the manuals that I have written can help healthcare professionals like yourself to provide that teaching. So the modules do follow Kolb's adult learning model. I'm going to be talking to you about that today. And they're laid out so that it says what you do and say as a facilitator, what is the expected response from your client to show that the learning is taking place. And there's lots of handouts included that can be copied as much as needed whenever you're providing patient teaching or client teaching. So that brings us to the learning objectives for today. So the first one is to distinguish 4 categories of coping and corresponding strategies. So having a structure to screen and provide interventions for coping strategies can improve efficiency in decision-making and client collaboration. So we're going to start with that. Then once we know what to teach, we need to know a process to help the learning stick. And that is where Kolb's adult learning model comes in. We're going to look at 6 behavior activation methods that will help clients to engage in the teaching and recovery. And then finish up with valuing 4 outcomes for preventing relapse. And we're going to use a questionnaire, polls, demonstration of relaxation techniques, and case examples during the session. And I'll just let you know that I can't see the chat while I'm doing this. So Sue is going to be my right-hand person to help out with providing any of the comments in the chat my way. So there's going to be some opportunity for interaction and discussion, and I'm going to try to leave about 10 minutes at the end for further discussion. So there will be some questions I'll ask you to answer as we go through the presentation today. So we're going to start by looking at the coping strategy content. So this is a picture of me. Not to brag, but that is a double bullseye that I've got there. So I spend time playing games and time with friends to help manage my stress. It's fun and it's energizing for me. So I'd like you to think of one thing that you do to cope with stress. If you want to add it to the chat box, you can. But I'm thinking that if I asked everyone to share their example of how they cope with stress, we could have 100 different answers or different ideas. And that's because there's a lot of different ways to cope with stress, and it can be overwhelming or confusing to know what strategies should we actually be teaching, because they can be general but also very individual. So we're going to look at a way to simplify this decision-making process. So we'll start with looking at what happens to occupation and activity whenever we are stressed or anxious. We're dealing with loss, pain, and illness like stroke recovery, and how that impacts our ability to engage in occupations or meaningful activities. So there's often a decrease in our health routines like sleep, exercise, and nutrition, which impacts our energy for activity. We don't really feel like doing things, and so there's less goal setting. We withdraw from others. There can be intense emotions in the fear, anger, and sad family, where we avoid activity. But also, if you've ever had that experience of really high anxiety, when we're in that state, it's really hard to reason and problem solve. And then we also get these negative ruminations that show up, the junk thinking, I call it, like I'm a failure, I can't do anything right. And that really zaps our motivation to try new activities and to take risks. So when we introduce coping strategies, that's what helps us to initiate and complete those occupations and activities that are important to us. So, for example, for health and wellness routines, we'd want to look at improving sleep and nutrition, and that will help our energy. When we set goals and manage our time and communicate our needs, it actually helps us get some control over the situation. And then if we have some strategies to manage those emotions, so our physical and emotional reactions, that helps keeps us calm so that we can then go on and problem solve or figure out our next step. Plus, it's very exhausting to be in these intense emotions for a long period of time. And when we have some strategies to recognize and challenge negative thinking, that will help us to take risks and try new activities. So that brings us to these 4 coping categories. And again, I'm going to refer to Brian and Corey. They didn't really know what they needed when they were feeling that stress. And I've certainly had that experience where I ask clients, what would you like help with? And they'll say, I don't know. Or they'll say just this general idea, like I want to cope. And so then it can be difficult to specifically define what would be of a benefit. So what's helpful for me and for my clients, if I break it down into categories first, and then look for gaps in coping within those categories to then help decide what strategies to teach. So the categories are taking care of health and well-being, changing or managing the situation, changing and managing my body's response to stress, and changing my attitude. So the next 4 slides include some survey questions that I'm going to ask you to just answer yourself. We don't have to share that information. And I just want to let you know that you do have a survey that's a little bit more detailed as part of your handout package. And it's called Stress Coping Strategies that I use from the module 4 categories of coping strategies. And it's one that I can use as a starting point with clients when they're really not sure what their needs are for coping. So whenever you have somebody say, well, I'd have no coping skills, this survey is able to actually show where their strengths are, as well as to show where there might be some needs. So over the next 4 slides, then I'm going to ask you to evaluate your own use of these strategies. So for health and well-being, do I regularly eat nutritious meals, maintain a healthy sleep routine, exercise, limit alcohol and other substances, take medication as prescribed, contact my supports, and balance self-care, productivity, and leisure? So take a quick look at these and decide if you're doing really well in this area or if there are some significant gaps. And then for changing or managing our stressful situations, do I regularly determine things that I can control, set goals for change in those areas, use assertive communication, set limits and say no? That's often a tough one for healthcare professionals. And also manage my time well. And then for changing and managing the body's response to stress, do I regularly notice my early warning signs of stress? Do I use deep breathing or practice relaxation techniques? Do I talk to a friend about how I feel or go for a walk? And do I distract myself with a physical or pleasure activity whenever my emotions are running high? So again, looking at strengths in this area and any significant gaps that you notice. And then for the fourth category, changing attitude, do I regularly count my blessings, recognize and reframe negative thoughts, use affirmations and positive self-talk, consider the other person's point of view, give myself credit for the good things I've done, and choose my battles while letting others go? So just as you take a look at these, I'll give you a heads up that we're going to do a poll in a moment. So moving on to this. When we reflect on the four categories of coping, I'd like you to answer this poll that they're going to put up in a moment. What are my categories of strength? And you can check as many as apply to you. So if you think all four are strong for you, that's great. There's no right or wrong answer. It's just really looking at where are my strengths. That's great to see that the health and wellness routines is often what is really eroded when I see people coming into acute psychiatry. So that's a nice one to see that's fairly strong with this group. It's great. Okay, so you can close that. Great. So let's imagine that your client completed a similar survey. What might be a question that you would have for them? Is there anybody who has an idea of what you might ask your person if they completed this survey?
Moment to type in the chat.
Is there one question that comes to mind?
Is there anything you might like to incorporate into your routine?
Great.
Or what area stands out for you?
Yeah, I love both of those questions. So what's an area of strength? Maybe what's your reaction to the number of coping strategies that you use? And then again, if there's a strategy that might help you do something similar to the questions that we heard in the chat. Thanks. Okay, and then the other thing I wanted to ask you is at the bottom of this slide, so what are the benefits of having strategies in each coping category? This one I'll just let you think about for a moment. But I do bring this one up because each category brings something unique to our coping repertoire. For some reason, I can't move my slide ahead. Oh, that worked. Okay. So thinking of the benefits for managing the categories of stress for health and wellness routines, that reduces stress by reducing change. So when we're stressed or just in general, our body likes to have predictability in our day. Things become much more automatic that way in terms of health routines. And anytime we introduce more change in our life, there's going to be more stress. So routines are one way to help reduce some of that change. To change and manage the situation, that helps us to take control where we can to manage a task. So let's say you are having a family dinner party or a family meeting. Let's say that you're having a family meeting. You can't really eliminate that stress, but the things that you can do to prepare for it is to set some goals for the meeting, maybe talk with the others using assertive communication, who's going to discuss what, know what the limits could be of the meeting, and managing the time. And then to change or manage the body's response to stress, those techniques really help us with the fight, flight, or freeze response. So this is just when the emotions are high, we need some strategies to just deepen our breathing, slow down our heart rate so that we can then reason and problem solve better. And then to change our attitude, there's that strong connection between what we think and how we feel. So if we can change those negative thoughts, it's going to reduce the emotion intensity. So the negative thoughts can create this forest fire of emotions. And if we can change that, it might be able to bring it back down to campfire size. Okay. So we're going to put the strategies into context. And I've got a quick overview of the stress response. So some of you might recognize this from CBT concepts. Something happens, it's the facts only. Then we put our interpretation on that as either positive, negative, or neutral. That leads to an emotional, physical response and behavior. So Jerome's asked to self-propel his wheelchair. He thinks he's going to fail, and that leaves him feeling anxious, overwhelmed. And so the behavior is lashing out at staff, refusing to do anything, and withdrawing, and also not eating. So if we think about which coping category targets which part of the stress response, we can look at starting with changing the situation. So in the situation, asked to self-propel the wheelchair, he could set some small goals for this, express his feelings assertively. To change his attitude, that would target the appraisal. And he could reframe his negative thoughts to, I'm going to do my best, I can learn this. To manage that body response, he might try some deep breathing or listening to music while he's doing the therapy. And then for health and wellness routines, that's going to help us be resilient at all stages of the stress response, because let's face it, whenever we're fed and rested, we can think better and we have better management of our emotions. Okay, so the stress response, let me just show you this chart. We have the stress response, we have the coping category that targets each stage, and then we have some examples of strategies that could help. So each category brings us something unique to our coping. Now, when you work with a client, it's important to be mindful that you screen for gaps in these areas. And when you notice some big gaps in their coping categories, just remember that can really impact their reasoning and problem solving. So the stress brain is going to see things more negative than it actually is. And it may not be the best time to make big decisions like DNRs or relocation. Really, at this point, we want to focus on stabilization of those routines. And then also helping with some of those calming methods. So with that, when that anxiety is high, it's really hard to think forward. And it's exhausting, so we really want to think about sensory and soothing activities and distraction for rest and recovery. And it doesn't have to be a long period of time. Like I'll have people come in and they're really anxious. Should they be calling the school or their work right away? And I just say, your job for today and tomorrow is to make sure that you eat. We're going to try and get into a bit of a sleep routine, take your medication, and then in another day, we can look at making this decision. But first things first. Okay. So with Jerome, whenever he uses some of these coping strategies, then he can overcome the avoidance to practice the techniques for maneuvering the wheelchair. So making some effort to eat at each meal, set some small goals, take those deep breaths, and change the negative talk to I need to use some positive self-talk to improve my anxiety and my recovery. Okay, so now I'd like to show you 2 examples to illustrate how starting with the coping categories assessment can then help to decide what strategies to teach. So first, a personal story. I'm a little bit of a nervous flyer, and on a family trip out west, I was practicing my coping strategies. So leading up to the trip, I made sure that I was eating regular meals and keeping my sleep and wake times. On the plane, I was using my relaxation techniques and listening to some calming music. And then whenever that thought came in my head, like I'm going to crash, I would say, this is really good for our family. We're going to have a lot of happy memories come from this trip. And then as I was flying, I look over and my son, who's about 12 at the time, is watching episodes of Mayday, which is all about plane crashes. And so, I don't know, I tried to look away, but my head kept drifting back and I was starting to get more stressed. And so, again, there's a poll coming up. If you could get that ready. I'd like you to think about which coping category had I missed. So was it health and wellness routines, changing or managing my situation, changing the body response to stress, or changing attitude? Which category had I missed on my flight? Okay, good. So everybody realized I was doing okay with my health and wellness routines. So it was actually changing my situation. So there I am on the plane. My son's watching this show that's kind of stressing me out, and I can't leave the plane. So what could I have done to manage that issue? Does anybody have an idea? It's okay. I didn't have an
In
idea
the
on the
chat,
plane.
they're saying use your ear pods for music, turn on your own show or a meditation app, ask the son to turn off the screen, change seats with someone else from your family, close your eyes and look away.
Okay, great. Okay, so actually, it was my daughter, who's younger than my son, who turned to him and assertively said, "Can you turn the channel? Because this is really freaking me out." And so that assertive communication made the situation better for both of us. So changing the situation is about setting goals, using your assertive communication, and managing your time. So to help communicate, oh, I'm sorry, I'm having a bit of trouble changing my slides. I think it's right after the poll, I guess. Yeah, there we go. So just try to plug in some little tools here for your use. So when there's a difficult conversation to have, sometimes this desk script can be helpful. And this is information from Bauer and Bauer, but we do have a module about it in our book. So there's 4 steps to what you would say to somebody. First, describing the situation. You're watching a show about plane crashes. It's hard for me to look away. And you say how you're feeling. I'm feeling anxious. I need you to change the channel. And then to state the consequence or compromise, you'd say, well, that would help me feel calm. So this would be an example of a tool that you could use to help with assertive communication. And then I want to look at a case scenario with Christine. So she is 67 years old, single, retired, and has a small dog. She likes to golf and hike with her friends and their dogs. She's home 4 days post-stroke with some left arm weakness and a facial droop. She is right-handed. And her day is not going so great. She's sleeping a lot in the daytime and watching lots of TV, and that makes it hard to sleep at night. She's having trouble dressing herself. She feels anxious and she's isolating because in her mind, the facial droop is ugly. So she's having gaps in each of the 4 coping categories. So for each coping category, we can think about a need for Christine. So for example, with the routines, what she might need is a daily schedule to follow and some activation in the day to improve her sleep at night. To improve her situation with her stroke recovery, she might need some help with setting some SMART goals and maybe communicating her needs to others. To manage all that anxiety that she's feeling, we could teach a technique like box breathing, You breathe in for 4, hold for 4, breathe out for 4, and hold for 4. And then for attitude, she's saying lots of negative thoughts here, so helping her to recognize and challenge those negative thoughts. So thinking about that, which category would you start with and why? You don't have to answer that. You can if you want, but I'll just get you to think about which category would you start with and why? And I can tell you that there's no wrong answer. But what could be helpful is if you do some teaching with Christine about the 4 categories of coping, and then ask her to choose the one that she wants to work on. So let's say we do this and she decides that she wants to do some work on improving her thinking. So she says, I want some help to recognize and replace my negative thinking. Maybe this would help me feel comfortable to reach out for friends and walk the dogs together. That could increase my activity in the daytime, so I sleep better at night. And then, of course, I would need to nail down those strategies to help me with my dressing. So because Christine has chosen to work on recognizing and replacing the negative thinking, we could introduce the topic by saying there's a strong connection between what we think and how we feel. A distortion in our thinking will lead to intense and distressing emotions. And some examples of distortions are all or nothing thinking, when you hear words like never or always, labels like stupid, crazy, or lazy, or mind reading, assuming that others are thinking negatively of us. So after reviewing the types of thinking, then we could ask Christine to say, what type of negative thoughts is she expressing? So she says that the friends won't want to be around me is that mind reading. And then the next 3, facial droop is ugly, can't do anything, things don't work. That's your all or nothing thinking. And a label is just another form. That label of ugly is just another form of all or nothing thinking. So she's recognizing what these negative thoughts look like. And so then we might ask her, so what are some words that you notice in all or nothing thinking? So it's words like never or can't or ugly or not working. So those are all or nothing statements. And ask, how does this type of thinking fuel distress and why? And you're looking for those answers like, they make me feel so anxious and then I don't want to be around other people. And then a more balanced or compassionate thought. We could take the example of I can't do anything and ask her to come up with a more balanced thought where she's able to say, well, I can feed myself, I can use my computer, and I can walk. So then next, we want to help Christine to sort out facts from perceptions and reframe a negative thought to help her initiate an activity. And in this case, it would be connecting with a friend. So this outline of questions can help Christine with getting the information to manage and challenge negative thinking. So we look at the facts, right-handed, experiences left-handed weakness, and has a facial droop. The negative thought is others are going to see that I'm ugly, which leaves her feeling scared and sad. The compassionate thought that she comes up with is my friends do value and care for me. And the constructive action would be to call that friend and say how she feels and ask for support. And with that constructive action, it might be a good time to use that desk script again to help make that phone call. So now it's a chance to evaluate your learning. So here I've got a slide. You can just type your answers in the chat box. And once we get 4 or 5 correct, we'll just bring it back to the large group. So match the coping category on the left with the coping strategies on the right.
Mostly 1B, 2C, 3D, and 4A.
Yeah, that is correct.
Is that correct?
Well done. Whoops, I'll just go back. So yeah, taking care of health and well-being is your regular routines. So that's 1B. Changing or managing the situation is your goal setting. Managing your time and assertive communication. So that's C. 3 matches up with D, the relaxation techniques, and then 4 matches up with A. Thanks, everybody. So that means that we've completed our first learning objective, which was to distinguish the 4 categories of coping and the corresponding strategies. Now, we do usually, as healthcare professionals, we do have a lot of knowledge on coping strategies that we ourselves have learned over the years or had through our schooling, including the importance of setting up routines, use of SMART goals. We probably could help people link to relaxation techniques or cue them on some deep breathing techniques. We know that music is calming, so we could help with that. And certainly we're often encouraging others with self-talk. So we do have some knowledge, and the categories can really help us to identify where there are learning needs and gaps, as well as the clients to help identify that. And then it can help us to collaborate on appropriate interventions with our clients. Okay, so take a moment to take a deep breath yourself right now. So we're going to go on to the next section. So I wonder if you have been curious as to why some learning sticks with you, while at other times it's like it never happened. Or why clients tell you that they've never learned something that was addressed earlier in a session. And the answer could be in the teaching or the learning process. Often in healthcare, what we do is we provide education by giving a handout or providing a demonstration or giving some verbal information. And this will provide an experience only that captures the client's attention. But the experience isn't enough to cement the learning. We need to include some other actions. So here's an example. You may have noticed that when you've been a passenger in a car driving to a new destination, you have arrived but haven't really learned the route. So looking out the window or listening to the GPS provides you with an experience only, but we need to include other actions to learn. David Kolb was an American education theorist and said we learn best through experiential learning, which involves doing, reflecting, thinking critically, and doing again. And his work describes 4 stages that adults follow to learn. So whenever we set up a learning session, there's actually 7 steps that we need to go through. And the adult learning model comes in at step 6. So I'm going to go through these in a bit more detail. So the first part is to identify that learning need or gap, which is what we talked about in the first part of this talk today, screening for strengths and gaps in those 4 coping categories. Once you identify a learning need, then we are going to go to step 2, which is to define the learning objective. And the learning objective really outlines what is the purpose of the learning session. It's often an observable action that relates to 3 domains of learning that are sourced from Bloom's taxonomy. So they are knowledge, skill, and affect. The knowledge is about information acquisition. Skill is being able to demonstrate the use of motor skills, and affect is about buying into the learning. So valuing it, saying you're going to make that change, committing to making that change. So different from the other 2 for sure. And there's an example of hand washing. So you might be able to state 2 benefits of proper hand washing. That would be knowledge. You can demonstrate proper hand washing techniques. But we also need to commit to washing our hands between clients, or really our learning objective would not have been met. So a good way to remember this is the know it, show it, but also own it. So a little quiz for you. Read the following examples and identify which domain of learning is represented. So let's do the first one. The client will commit to taking medication as prescribed. Is that knowledge, skill, or affect? I'll wait to hear an answer.
I'm saying affect.
Good.
Affect.
Yeah, okay. And then the client will name 2 types of cognitive distortions.
Knowledge.
Right.
Knowledge.
Okay. And then the client will demonstrate the box breathing technique.
Skill.
That's good. Fantastic. All right. So it's a nice time to reflect quickly on your practice to see what domains of learning do you evaluate in your practice. Okay, but we'll keep going in the interest of time. So the next step, after we have identified the learning need, we have defined our learning objective, then we want to gather everything that we need to provide the learning session. And then moving on to step 4, where we consider relevance and context. So Knowles was another adult education person and said that adults like to understand the significance of the learning to their lives. So it's essential to begin with the learning session by putting some context into real life problems or situations. So remember I talked to you about being a passenger in the car and not learning the route? If the driver had said to you, we're doing a dry run so that you know how to get to your job interview tomorrow, you probably would have been more interested or motivated to pay attention differently to that route. We also want to clarify the agenda to talk about what's going to happen during the session, how long will it take, and how is their learning going to be evaluated. So that brings us to step 6, and this is where the actual learning takes place. This experiential learning process outlined by Kolb was called the adult learning model, and it's a cycle of 4 stages: experience, reflection, generalization, and application. And it's the questions and activities that you present as a facilitator that takes the learner through all 4 stages. And remember that your learner can be the client, but it could also be a carer, or it could be your colleague. And you'll see that in the middle of that is a learning objective. So we figure that out before we do the learning, and then when the learning cycle is complete, we evaluate if that learning objective has been met. To provide every possible opportunity for the information presented to be transformed into learning, we need to take our learners through all of the 4 stages. We're going to look at each stage in a little bit more detail. So the first stage is that concrete learning where you provide an experience. It captures their attention, captures their senses, it generates information. So this could be providing a handout or giving some verbal information or a demonstration, but it could also be playing a game or watching a video, do a brainstorm session. Then we want to move on to reflective observation. And this is really about recall, recognition of the information, and also finding out about their reaction to their information. So some questions here could be, what stood out for you, or what did you notice? Asking how the experience made them feel is really important. So if they're feeling overwhelmed, it's going to be hard, or really frustrated, it's going to be hard for them to continue to learn, because the emotions are running really high. So this is a time to validate, to reassure, to maybe break down the information a little bit more for them, so that they're comfortable to continue on with the information. And then the third idea is, if you have somebody who's having some communication challenges, maybe you could use pictures like a thumbs up or thumbs down to represent their reaction. So they could point to a picture to represent their reaction from the experience. Then the generalization stage is next. So this is a higher level of learning. And this is where the learner will start to make some connections and draw conclusions, or consider the implications of the experience and the learning. This is a time where you're going to ask about pros and cons of the information, or what barriers do you anticipate, and what solutions might you suggest, and why. When you ask that question, why, it promotes a deeper level of thinking. Okay, and this is really great to give them a moment to talk about what are the barriers and come up with some solutions. We might glide over that and miss some real opportunities for finding solutions. And then finally, we have the application stage, which is the time to test the conclusions, to practice, or to think about and state how they're going to use the concepts in their personal life. So questions here can be, how would you apply the learning? What's something you would do differently now? And maybe what support or resources do you need to implement this? So once we've gone through the 4 stages, experience, reflection, generalization, and application, it's time to evaluate that learning objective. And you really want to include some time for this in your learning session so that it's not homework. If they've learned it within the session, there's a much higher chance that it's going to be carried over to their personal environment. Okay, so for the example, if you have a person in your session do an affective performance statement where they commit to contacting a friend, that commitment of contacting a friend could be your meeting your learning objective, where you want them to increase their social support. And then they may then go off and do that actual call outside of your session. But within the session, it could be that you're just asking them to commit to doing it. Okay, so we're going to go through learning a teaching session for Benson's relaxation technique. And I'm going to take you through the 7 steps of a learning session, including Kolb's adult learning model. So first of all, we have identified a need for some relaxation education. And so our learning objective is that given relaxation practice, discussion, and feedback, the learner will explain Benson's technique to the extent that 2 ideas of the prescribed technique are named as evaluated by self, peers, and facilitators. And being able to explain Benson's technique is a knowledge domain of learning. So we're going to get ready to relax in a moment. So first we'll provide some relevance and clarify the agenda. So often worry thoughts increase our anxiety. Benson's technique manages and stops these negative thoughts or worry thoughts because we focus on repeating a word as we breathe out. We're going to practice the technique for about a minute, discuss, and then evaluate your learning. So I will ask you just at the moment to get into a comfortable position. And if you'd like to close your eyes, you can do so. So this is a technique that uses a sound or a word, which is repeated silently or out loud if you're doing this on your own. And it helps to break any train of distracting or distressing thoughts. So begin by breathing in through your nose and becoming aware of the sensations of breathing. Be aware of the sensation of the air passing in through your nose and the rising and falling of your chest and abdomen. Focus on these sensations, and as you breathe out, say the word 1 quietly to yourself. Bring your focus of attention more and more inward to the sound and sensations of breathing and repeating the word 1. If you find your mind wanders to other thoughts, don't worry about it. Just come back to the practice with your next breath. Breathing easily and naturally. And as you breathe out, say the word 1 quietly to yourself. Okay, and now we'll get you to come back. So you might want to wiggle your fingers and your toes, maybe sneak in a yawn. Okay. All right, so just get you to think about these answers. So what did you notice as you did the technique? What's a benefit of tying a word to your breathing to manage the stress? How is that helpful? So maybe it keeps you grounded and focused. Think about how you could practice this technique on your own. So maybe this is something to do before going to sleep at night or on a crowded bus. Very portable. And think about how you would explain the technique in your own words. So I've popped up the learning cycle here for this technique. So if it's something that you want to do with your clients, you've got a resource to go back to with the 4 stages of the learning cycle. And the evaluation. So what you want your learner to walk away with after doing that session is to name the 2 key ideas of Benson's technique, which is to repeat a word and tie that word with the breathing to refocus the attention away from worry thoughts. Okay, so I've just provided you an experience of Kolb's adult learning model. Which is the correct sequence of the 4 stages of Kolb's adult learning model? Is it A, B, or C? I'll get you to put the answer in the chat.
A, C, 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 C.
Yeah, the answer is C. Good. Okay. So this is also a good time to ask, how are you feeling about the information? Are there any questions?
We did post the technique in the chat for people that may not have received it through my email, so you can download it there.
Oh, okay. Yeah, the Benson's technique, there is a handout about that also in the handouts. Yeah.
Yeah.
Okay, so by asking the 2 questions, do you know the sequence, which is C? And do you feel comfortable with the information? We can move on from reflection to generalization. And you might think about what are some benefits of using Kolb's adult learning model in stroke care and why. So see if you agree with some of these. It's a collaborative process with shared decision-making. It really does involve a lot of active participation and it's goal-directed. Now, I know I'm not always giving you the opportunity to answer the questions as I go through it, but with your client, they would have the opportunity to answer these questions. So that makes it more active participation. And then it can be tailored to a lot of individual needs. So you can use oral, written, or picture information to help with the learning. And then an application question could be what's something that you would add to your teaching method based on Kolb's adult learning model. So let's take a look at Christine again. So she is having trouble dressing herself. And when you show her some techniques, she says she's never going to learn how to dress herself and she won't be able to wear clothing she likes again. So she's feeling overwhelmed. Now, we have done some teaching with her already about this negative thinking, but let's try another coping strategy. So we'll provide some teaching on the SMART goal format. I know there's a couple of different ideas for the acronyms, but I like to use specific action, a measurement, why it's acceptable to you, because if you can say some reasons why this is a good idea, you'd be more willing to do it. Is it realistic and is there a time frame? So Christine, you're going to teach her SMART goals. So what's the correct format to do this SMART goal teaching with Christine? Which part of this is the experience? Which letter represents the experience? And then does anybody have the answer to that?
Not yet. Just type in the chat, please.
Okay.
Maybe repeat the question, Theresa.
So what's the correct sequence for Kolb's adult learning model if you were teaching SMART goals? So it might be helpful if we just do it one at a time. So what would be the experience?
A, B, C, or D, right?
Right.
People aren't sure.
Not sure? Okay, I'll give you,
C. I got a C. I got a few
it is.
C's.
Yeah, okay. So the first part is you're going to give them some information. So you're going to tell them what a SMART goal is. Then we want to do a reflection, which is some kind of a recall or a recognition or sharing the reaction to the information. So what do you think is the reflection question here?
A.
A is a generalization question because we're looking at benefits or challenges, and we've got that question why to lead to the deeper level of thinking.
Anybody else? B. B.
B, yeah, it's B. So here we're trying for some recognition. So we give her a statement, I want to dress myself, and we say, what components are missing from SMART with this goal? And the answer we're looking for is that it doesn't have a measurement and there's not a time frame. So that's your reflection question. Generalization and what's the benefit of stating all 5 components when setting a SMART goal. And of course, it helps to break things down, make it more manageable. And then the application piece. So this is where she gets to practice SMART goals and reformatting a goal in the SMART format. So take that goal, I want to dress myself, and change it into the SMART format. So here we've talked about the first 3. So for the application piece, Christine reformats her goal. I want to dress myself into the SMART format. And it looks like I'm going to put on my top within 5 minutes. This will improve my independence. I can use one-arm dressing techniques, which helps make it more realistic. And I'll practice every day for 5 days, which is a time frame. Saying this improves my independence and success is the reason why it's acceptable for them to do the goal. So then we would evaluate, and this is the affective domain, where Christine commits to using the SMART goal format to help her with dressing. Okay, so this is really measuring the coping strategy of setting SMART goals. It's not measuring her dressing. It's just measuring a strategy that will help her to initiate that dressing. Okay, so how are people feeling about meeting the second learning objective? Do you think you have an understanding of how to sequence the 4 stages?
We do have a question, Theresa.
Sure, yeah.
Someone is asking, do you have any suggestions of how to use the CBT type approach with stroke patients who are experiencing cognitive challenges or changes?
Yeah, so if to recognize and replace the negative thinking, sometimes it's a little bit more complicated. So I have some simpler techniques, like just using words of wisdom. Words of wisdom are those kitchen table wisdoms that have been handed down by generations. So they're very simple statements like, I've got this, or one day at a time, or don't cry over spilt milk. Those are some different ones that come off the top of my head. But for people who are having a little bit more difficulty with abstracting the concepts, it's a simpler approach to remind them that what they say in their mind will impact their emotions. So that possibly could help. And if there's a communication gap, then maybe again, using some pictures to represent these different kinds of kitchen table wisdoms might be helpful.
Thank you.
Are there any other questions at this time?
Nothing in the chat.
Nothing coming out. Okay, I do want to say, like, this is, you're getting this information in about 20 minutes and it's not always so easy to wrap your head around it. But that's why the books, that's why we created those books, so that it will really help break down what does each stage look like, with questions and activities that you can do at each stage, and then what you're kind of looking for in terms of answers from the learner. So the books have been set up to do in groups, but it's very easy to adapt the sessions and the concepts into one-to-one sessions. But really important that you still keep that 4-stage sequence. Okay, so we'll keep going. I do want to take a bit of time to go through some behavior activation techniques. Just find out where I'm at in my notes. Yeah. So behavior activation techniques are when things that we want to use when it's very hard for them to engage in activities because either their mood is really low or their anxiety is really high. So we need some strategies to help them get unstuck. And the strategies are things that will help them get into movement, experience pleasure, or have an achievement. Okay. So that's kind of the idea we're getting for. We want them moving, to have some pleasure experiences, and to have some success experiences. And what I'm going to talk about specifically are these techniques that help them to get started so that they can experience that movement, pleasure, or mastery. So whenever we're facing a challenge or a stress, our behavior can be constructive, where we choose strategies that help us engage in that challenging activity. Can be destructive, where we might make the situation worse, like self-harm or substance use or lashing out. Or we can go into avoidance, where we withdraw from others, procrastinate, or just get into distraction for long periods of time. So to overcome avoidance, we want these techniques, simple techniques, that will just help the person get started. Because if we can get them started, there's a much higher chance that they will continue. So I'm going to go through a scenario again with Xander, who's 72 years old and is admitted following a stroke. He's feeling overwhelmed and anxious, and he's isolating, staying in bed. He's often refusing therapy and saying, "I can't do anything." So this is a good opportunity to teach some of these behavior activation techniques. So one strategy is, again, providing that context or relevance. It's the first step, as it is with any other type of teaching. Because when you do this, it provides some buy-in to the learning. Okay, so if we said to Xander, sometimes the stress we experience causes us to avoid action and withdraw from others, but not doing leads to further avoidance and a why bother trying type of thinking. So these behavior activation techniques can help us move towards action, pleasure, and achievement. So just trying to provide some context. And then we can have some of these in our back pocket. So the first idea is a time task, where you set a goal for a small amount of time to do something, and that will often help them to get started on the task. When the time's up, they get full credit, but what often happens is that they're willing to continue. And I will often use this to help people come to groups. So if they're not sure, I'll say, just come for 10 minutes. If after 10 minutes, I just say 10 minutes because it gives you a chance to get a feel for what the group's about. After 10 minutes, if you want to leave, no problem. And I would say that the majority of people do stay once they actually get into the group. The next strategy is breaking things down into really, really small steps. This is one probably many of us are familiar with. And how this could look at, like, for contacting a friend, you could say, just want you to name the friend, locate the number, practice 2 things you're going to say to start the conversation, and then make the phone call. I did this with a patient just last week who was very stressed about calling her lawyer. And we broke it down into these steps, and then she was able to move into action. The next one is a prediction log, and this works because it engages a person's curiosity. So the anxious brain or the depressed brain is going to think that things are more difficult than they are, and they're not going to enjoy them, so why bother trying? Okay. So this is a way to retrain the brain a little bit. So you can rate or you can predict difficulty of doing a task on a scale of 1 to 10, 1 being the least difficult, 10 being the most. You do the task, and then you rate the actual difficulty. And most often what happens is what they predict in difficulty is going to be higher than what the actual difficulty is. In the same way, we can predict pleasure of a task. So the prediction will be that the pleasure of doing the task will be quite low. They do the task and then they rate the actual pleasure, and it's usually higher than what they predicted. Even if the difficulty is, when they do the task, is as high as they predicted, it's still telling them that they can do difficult things. So it still helps them to move into action. So I'll just give you an example here. So Xander predicts a difficulty of shaving to be a 9 out of 10, 10 being the most difficult. Then he's set up to shave and reports the actual difficulty to shave was a 6 out of 10. So less, the actual score is less than what he predicted. And he says he's feeling pretty good after the shaving was complete. So here's the learning cycle for teaching behavior activation techniques. It's just a condensed version from the book. So you could explain these 3 techniques: the time task, the graded task, and the prediction log. Ask them which one was most interesting for you, and then ask how could the strategies be helpful and why. And the answer you're looking for is that they're able to conclude, starting on the task will help me to keep going on the task. And then as a little practice, you could say, myself as a facilitator, pretend that I'm having trouble getting started to brush my teeth. What motivation strategy could help me, or what activation strategy could help? Time task, graded task, or prediction log, and Xander picks what might help. And then moving on to evaluation, this is a bit of a repeat because I put this a little bit earlier too, just so that you understood what prediction log looks like. But after doing the learning cycle, then for Xander, we'd ask him to identify a self-care task that's been challenging for him to complete. He says shaving. He uses a technique of the prediction log, predicting a 3 out of 10 in pleasure for shaving, but on completion, he says it was an 8 out of 10 in terms of pleasure. And then there's a couple other techniques to have in your back pocket. The first one is team problem solving, where you say to the client, I'm not really sure what's going to help, but maybe you could help me find a solution, or we could think about this together. Very empowering for the client. Or offering choice. So here you need to include 2 options for occupation. So if you say, do you want to brush your teeth or comb your hair? The message is it's still time to do something, but I'm just going to reduce the cognitive effort. So instead of saying, what do you want to do, which takes more effort, I'm going to say, do you want to do one thing or another thing? Really important, that is 2 options for occupation. If you said, do you want to have a shower or not, opens the door wide open for them saying, no thanks. So we include 2 options for action. So how this could look for Xander, for the team problem solving, you could review the 4 categories of coping with Xander and say, I'm not sure which one you want to work on to help reduce anxiety. Do you have a suggestion? I use this a lot with my clients. And Xander chooses to prioritize changing his body's response to stress by learning a relaxation technique. And then you're able to step in and teach him the Benson's relaxation technique. Here we can use the offering choice. So do you want to use the breathing techniques to help you relax so that you can practice balance exercises or washing your face? Again, we've got 2 options for action. And the relaxation technique is just to help him move into doing that activity. So here's a summary of the techniques. There are 6 of them, providing relevance and context: time task, graded task, prediction log, provide choice, and team problem solving. So just, I won't ask you to add this to the chat, but think yourself, which is a technique that you find most interesting. When you run into a barrier with a client, which one do you think you might use for empowering the client and why? So Xander, he's saying, I'm so anxious, I just can't do anything. Would you try an empowerment technique like time task, graded task, prediction log, offering choice, or team problem solving? And what activity would you pair it with? So I'm providing an example here, 2 minutes of a time task of walking, which is your activity. Okay. Or you do the prediction log paired with the activity of shaving. All right, I'm going to keep going just because I want to leave some time at the end for questions. So I hope that's okay, unless there's any burning questions right now.
Nothing right now. We got about almost 15 or 20 minutes left in the session.
Okay, I do want to, well, you know what? Why don't we hear from somebody then? If there's no questions in the chat right now, does anybody have an idea of what behavior activation technique you would use with Xander and what activity you might pair it with?
Just type it in the chat and I'll read it out for Theresa. Someone's saying prediction log and walking.
Great. The nice thing about knowing these behavior activation techniques is if one doesn't work, you've got a bunch of others that you can choose from. So you can keep chipping away until you find one that works. I mean, if the person really doesn't want to do it, then you're going to walk away and come back. But I would say like 90% of the time, these techniques will help them to at least do something.
Another suggestion is time task of sitting in the chair for 5 minutes.
Yeah.
And another one is prediction log in addition to graded task.
Okay. So those would be 2 activation techniques. And then you would pair it with a specific activity.
Someone else is saying I try to link it with something he enjoys and had succeeded with in the past.
Yeah, that's another great strategy. Yeah. Good. Okay. So then we'll keep going to the last part and then we'll have some time for discussion. So we've met the third learning objective, which is knowing these 6 behavior activation techniques. Okay, so that brings us to the last leg of the race. For me, it really has improved efficiencies in my practice to choose 4 outcomes that I evaluate prior to discharging a client. So I start this already when I first pick up my referral. And it might be interesting to remember what Brian and Corey were talking about earlier about how some things were missed earlier on through their recovery process. So by knowing what you're aiming for as your outcome, you can start to address issues very early on with your interaction with clients. So the outcomes that I've chosen are where I'm aiming for before I discharge the client. So they include participating, that the client is able to participate in meaningful routines and activities, okay, so that I can get them to a point where it's good enough for whatever the next stage will be for them. The medication adherence, that's a really important one because often messing up the medications will bring my clientele back into hospital. Suicide prevention and safety and distress tolerance. So suicide prevention is something that I often face in my practice, but also here I would consider safety in terms of falls, safety, if there's cognitive deficits that might impact their safety at home, I would need to make sure that that's addressed before they are discharged from my service. And then also connecting with supports. So professional, peer, and personal supports. So I choose these ones because they are within my scope and team members, clients, and the literature review all indicate that these reduce relapse of illness and promote recovery. So now I might not do everything in these areas, but at least they're on my radar. So for example, if a person tells me they don't have enough funding or enough money to cover the cost of their medication, then I might talk with a social worker about getting involved to look at medication subsidy programs, or talk to the psychiatrist about looking at other options for medication that might be less expensive. So I've done some things like that in the past, but at least it's on my radar, and I see how we can get that to an acceptable level before the person moves on from my service. So I'm going to talk to you briefly about 4 modules that I use regularly for relapse prevention. And they include building healthy routines, medication adherence, suicide safety planning, and connecting with supports. So the first learning cycle that I have here is setting up a skeleton schedule for health and wellness routines. So basically what this one involves is they have a checklist of things that might be helpful in their daily routine to continue their recovery after they're done working with me. So that includes, regular wake and sleep times, connecting with supports, taking medication at the same time, eating 3 meals a day. There's a lots of lists, lots of things there that can mostly relate to the health and wellness routines. So they check off what they think will help them. And then a reflection question is, how does this compare to your routine prior to admission? What do you notice is different? For my population, they're often coming in and saying they didn't have much structure before they came into the hospital, or that fell apart. And so now, after being in hospital, they've got more of a routine on board, and that it has helped them with their recovery. The reflection is, what's a benefit of sticking to a routine and why? And then, of course, what's a barrier and what could be a solution? And then next, I asked them to set up a skeleton routine. So skeleton routine for a 1-day schedule. It has some things that will be the same every day, like, for example, their meals, but not every time slot has to be filled. So we've got a structure in place, but we also have holes in our routine so that we have some flexibility. And then to evaluate that, they include at least 5 activities that will help promote healthy routines and their recovery. And they'll take one of those activities and define it more as a SMART goal. So they'll spend 15 minutes outside every day after lunch for 2 weeks to improve mental health. So that's what I look at for their health and wellness routines. It just helps me to see that they've got some things for their self-care, for productivity, for leisure, some meaningful things that they're engaging in their day. The next module is medication adherence. So it has a list of things. This is also in your handout package, by the way. So it has a list of reasons why people don't adhere to medication, maybe worrying about side effects or forgetting to take them or stockpiling them for self-harm. There's a lot of different reasons there. The reflection question is, what did you notice? Did you have some ideas that sounded familiar to what you experienced? And also, how do you feel seeing that other people also struggle with medication adherence? And then you can ask about the benefits and the barriers to taking medication as prescribed. Really nice time to come up with solutions here. So I had one lady who had to get her prescription in on time, where she wouldn't get the generic, she might not get the generic brand of medication. So we talked about how to work with her pharmacist to ensure that the prescription renewal was in on time so that she could get the generic brand, which was less expensive for her. And then the second page of that handout lists some solutions to helping with medication adherence, like using pill boxes or blister packs, putting alarms on phone, lots of different reasons. And they go through and check off some ideas that they think might help them. And the evaluation is that they'll commit to actually doing 2 actions to improve their medication adherence, like maybe speaking to the pharmacy about medication delivery or putting a reminder on the phone, and they can do that right there in the session with you. I'm going to touch on suicide safety planning. I know this is can be a very challenging and difficult topic, so I'll just go over this briefly. So it's important to know that people that have had a stroke are showing a lot of risk factors for suicide. And with those increased risk factors, it's best practice to screen for suicidality and provide or link to interventions. It's also really important that you're direct when you're asking about suicidality so that the client is very clear on what you're asking. So here I've just put up some resources. So it's not meant to replace gatekeeper training, which is an introduction to suicide prevention. But on the Canadian Association of Occupational Therapists website, there is a network page that you can access. You don't have to be a CAOT member to access this. And there's some information on gatekeeper training, like length of the program, costs, where they're available, but also some great documents on suicide prevention, intervention, and postvention. And what I use in my practice is a suicide safety plan that's very comprehensive. It looks at warning signs with cues, coping strategies with cues, like what would be something I could say to myself, what would be an activity to manage my emotions, what could replace my negative thinking, who could I contact for support. So it says coping strategies, but it gives some cues for what they could put there. It also includes ways to reduce lethal means, naming supports and clarifying who's responsible for what when the crisis is present, as well as a list of some of these resilient things like eating regular meals, getting enough sleep that they can check off and prioritize to help their recovery. And then I'm popping up one more resource for you, which is helping people to connect with peer support. So you might demonstrate accessing the Heart and Stroke website to show the headings for social and peer support. Ask what's your reaction to the website or what's something that caught your attention as your reflection. Ask what might be helpful in accessing the website and what might be a challenge, what could be a solution to that challenge. And then maybe for the application, they could show you on their own iPad, they can demonstrate that they can actually access the website. And then for your evaluation, they commit to using their iPad to join a peer support virtual session in the next week through the Heart and Stroke website. Okay, let's check the time. Yeah, so now this slide has some questions to maybe take away to your team or to reflect on. So what outcomes like building routines or medication adherence or suicide safety, connecting to support might be similar to your practice? Maybe what's different with your practice? What's a challenge in meeting coping strategy outcomes and why? What's something to do differently now? And what's an action in the next week to improve the coping outcomes? And we have talked today about a lot of things that can help you with these coping outcomes, like modules on building routines, communication skills to connect with supports, that desk tool, replacing negative thinking, behavior activation techniques to get involved in the routine. So we've talked about lots of different things. We've talked about the Benson's technique to help people relax, and some strategies to help them connect with community supports. So that's our fourth learning objective, is to think about what would be your 4 coping outcomes and to value those and start looking at them early on when you are working with your clients. So that brings us to the end of what I have to say. The 4 objectives revisited were to distinguish the 4 categories of coping and the strategies, to sequence the stages of Kolb's adult learning model, to name 6 behavior activation techniques, and to value coping outcomes. These are my references. That brings us for time for questions or comments. And I will say there's one more slide after this where you're able to provide feedback on the presentation. So I'll open it up for any questions or comments that people have.
Thank you, Theresa. Lots of information, really good. We have some questions that have come in throughout the morning, so I'll just start with the first one. And how do you motivate the very negative or depressed patient to embark on a learning task?
Yeah. Okay. So I think first of all, make sure that they are connected with support so that the pharmacological needs have been met. If they are depressed and they're just starting an antidepressant, it can take up to 3 weeks before um, they start to see change. You might start to see change sooner than that, but for the client, they often don't start to notice that things are getting better until about the 3 week mark. So in that sense, really use your behavior activation techniques, provide that reassurance to them, offer choice for really small opportunities for success experiences. And I think what I really work with for people is really simple tasks that are repetitive in nature, because that can be very soothing. So things like coloring or weaving, I'm not sure if that would work always with your clientele, but it's something to think about. That some of these, folding towels, sensory things can be very soothing to the very depressed or anxious brain.
Great, thank you. Our next question is, someone is saying currently she builds schedules with clients for 1 week periods. I like the idea of building a 1 day skeleton healthy routine as you suggested. Is there any guidance whether using a 1 day or a 1 week schedule is more beneficial to clients?
So I focus very much on the 1 day schedule because I want to have that skeleton routine in place. But I will pull out the weekly schedule as well. So especially if the person is on their own or has a really hard time organizing their time. And then I plug in what's the stuff that would be just unique for a certain day in the week. Like a 1 week schedule, this would be where you might do your laundry, or this might be where you might go to that support group, so that their weekly schedule isn't very cluttered, but it puts in some of those unique events through the week. But the daily schedule is the one that they refer to every day and keep as structured and routine as possible.
Great, thank you. Someone is asking for an example of direct questions you can ask about suicide.
Yeah, so there are some resources on that CAOT website, but basically you are asking, are you having any thoughts of killing yourself? So it would be as direct as that.
Okay, great, thank you.
I'll just comment on that too. Sometimes it's a belief that if you ask about it, you're going to put the idea in their head, and that is a myth. So it's important to ask.
Okay, perfect. Someone else is asking, who are the resources that post-stroke patients can be referred to in the North? Now, I know, Theresa, you're from Ottawa,
Yeah.
but is there resources that are online or virtual or that tend to be across the province of Ontario that might be helpful?
There are, you know what, I don't use them that much because I have my own resources at work, but I think it's Big White Wall is one that people can access. But again, I will refer you to the CAOT website because I know there is a document there that looks at resources across Canada.
Okay, perfect. Thank you. I would also say for people online that our navigators will be speaking at the end of the day, but navigators will help seek out resources within communities as well. So if you can connect with the post-stroke program in your district, then they might be helpful with that as well. The last question here is, what would you recommend as general screens post-stroke for depression anxiety? We sometimes use the PHQ-9, but wondering if there are any other resources available. Again, I know stroke is not your forte, but
Yeah.
wondering about general screens.
Yeah, the PHQ-9 is a good one. If you're screening for suicide, the Columbia scale seems to be the one out there that has the most research, and that is most frequently used. We use that one in our practice, and our clients are screened every day. So it's just it's a quick tool to use, and I would say, the Children's Hospital of Eastern Ontario, they screen for suicide with every client that comes in about at the age of 8. And I think that's just such a great practice to get into the habit of asking the question. In terms of screening for depression, I guess I would, because I'm not a doctor, but I would really look at those 4 coping categories. Are they engaging in their usual activities? Are they being paralyzed by their emotions? Those two things are a really good place to start when you're screening for impacts on mood.
Great, thank you. So that wraps up our time today and all our questions from the chat. So once again, Theresa, I'd like to thank you for joining us today and sharing your knowledge. I always get requests about education around mental health because it's such a part of impact when people have had something traumatic happen to them, like a stroke. So I was really happy you could join us today with some really valuable information, and we really appreciate it. And on behalf of the group here, thanks so much for coming today.
Well, thank you so much for having me. I'm always happy to advocate for use of mental health resources.